Those are patients that I'm already considering TDXD in the first line. And so,
assuming DB09 is approved, we have patina,
yeah,
we have HER2
right.
we have DB09, and we still have Cleopatra.
Yeah.
Do you have a sense in your mind which patients you're treating on the, either of this regimen, or are you doing a mix? What is your thinking process?
Greg, this is the big question,
this is
right?
the big question.
Maybe I should turf it back to you.
I'll give you my opinion.
So I've already started having these conversations with patients because I think it's important to, be timely and talk through the data. Obviously, it's not approved, as you mentioned. I will say that it used to be a pretty straightforward conversation, right? We had the Cleopatra regimen, right? You had the Cleopatra regimen, and then over the past year, since we've seen patina, if patients had ER-positive disease, then we would talk about the patina regimen. So I would say that I do think that the patina regimen, in terms of tolerability and so on, I think that's really, really a critical regimen to have for patients. And I think many patients, we've all had them, can do quite well with THP. And the fact that you're giving endocrine therapy and you're giving, you're blocking HER2 and CDK4/6, that crosstalk, I think that biologically makes a lot of sense.
So you're sort of separating the hormone receptor positive.
Right. Whereas before it was kind of a one size fits all. Now I think that we're going to start to become a bit more kind of biomarker driven over time. The biomarker may now be HR status. But perhaps, we all have those patients that don't do as well on THP induction maintenance. And so, who are those patients? So perhaps if the tumor is associated with a PIK3CA mutation, then those are patients that perhaps we may need to start with the DB09 regimen, or patients who have a short interval, disease-free interval. Those are patients that I'm already considering TDXD in the first line. And so those are definitely patients that I would offer this, whether I'd offer it with pertuzumab or not in that setting with a short disease-free interval. That's something that we're going to have to digest. CNS disease as well.
Yeah.
We don't tend to screen the brain. And there's kind of a lot of debate about
and maybe we should.
Staging, and perhaps, perhaps we should at this point to help kind of, figure that out. Or patients who you really need a response now. And if patients have de novo versus recurrent, and again, that disease-free interval. So I think it's going to be more nuanced than it was.
Are you thinking you need to see TDXD only arm to really finally solidify? Because I do.
Yeah.
I think if TDX, the fact that we haven't seen the data, low events, may suggest that it's probably going to be a positive.
Yeah.
And I do think that if you TDXD only, if it has this sort of similar activity, really sort of maintains Cleopatra for a next line.
Right.
But because you don't have pertuzumab there.
Right.
But if you give pertuzumab in the first line, you essentially has gotten rid of Cleopatra. Because who's going to re-challenge with Cleopatra in the second line, at least without data? We do have some small data set, but we would need better data for that. So I think that population, for sure, I would need to see that. But if it's approved, I do agree that those high-risk patients, the PI3 kinase mutated patients, I think that's a DB09 patient for sure.